So this is quite an interesting case of a very brunescent mature cataract in a relatively young adult male, potential trauma history with phacoemulsification present. So important to get a good staining of our anterior capsule to be able to get a clear continuous curvilinear capsulorhexis in a patient like this. So just gave it a minute there to stain the capsule well, and also important to wash it out well so it doesn't obscure your view. Then filling up the anterior chamber with our OVD, making sure we get a good viscodilatation of the pupil so we have a clear view for our CCC. Now, approaching a CCC in a patient like this, I'm always nervous about it being a very brittle capsule or potentially having some hypermature portions which may result in a risk of an Argentinian flag. But in this case, I didn't see any white milky bits, so didn't approach it with the risk of an Argentinian flag. Just gingerly initiating the CCC and extending it, making sure that we get a good size. You definitely don't want it to be too small in a patient like this where you're going to be dealing with a large hard nucleus. But fortunately that seems to have gone relatively well. So our next step will be hydrodissection of the nucleus from the anterior capsule. Generally these large hard nuclei hydrodissect really well, but in this case, because of the loose zonules, we're just going to gingerly rock the nucleus back and forth to make sure that we get it really nice and free, and it's always a good sign when you see it spinning like that. Now, approaching this nucleus, this is a case where I definitely want to go for a primary chop to try and minimize the cumulative dissipated energy in this case. Important to make sure that your sleeve is on far enough that you have a good segment of your phacoemulsification probe extended out from the distal tip of the sleeve so that you can really embed the nucleus right down into the core, into the center. Then for our primary chop, this is my least favorite chopper that I'm using here. It's not quite sharp enough to do a vertical chop and not quite long enough to do a horizontal chop, as you can see here. But we're going to do the best we can and just try and break this nucleus up into multiple fragments. The more manual chopping you can do, the less energy you need to use from the phacoemulsification probe. So we're going to try and break this up into as many fragments as possible. Here, just as we break off one segment, can move on to the next segment before starting to actually try and remove the segments individually. What you can see here is that there's a leathery plate at the posterior pole of this cataract, which you often get with the brunescent ones. So the segment is not wanting to come up to me nicely, and I'm starting to have to dig for it, so I'd rather move on to the next one and deal with that in the meantime. So fortunately I'm managing to get some good phacoemulsification here, the Alcon Centurion working really hard. It might be a good idea to add some additional viscoelastic into the eye, sort of halfway through the case, just to protect the endothelium, but I don't think I'd do that in this case. So they're managing to split the segments from that leathery posterior plaque and separate into smaller segments. It would be nice to have a horizontal chopper here where you can actually go to the back and break off the segments from that plaque. I'm a little bit nervous with the slightly sharper chopper, however, but slowly making headway. This is the type of case definitely where slow and steady wins the race. You don't want to start getting impatient and hunting for fragments, and yeah, definitely risk for a posterior capsular rupture here with loose zonules, floppy posterior capsule, and dense brunescent cataract. But we're slowly making progress. Now this large fragment is facing the opposite direction from what I want it to be, and generally makes it more difficult to emulsify, so I'm just going to rotate it around so that it's in the correct orientation. I can actually approach it from the center, make your life quite a bit easier, and just continue to break it off into smaller and smaller fragments, as they say, eating an elephant piece by piece. I'll just continue to use the same technique, slowly chipping away at this final big fragment, and eventually the end is in sight. This is where I'm always nervous of the posterior cataract jumping up. I always keep my second instrument placed just below the tip of my phacoemulsification probe. Many times that saved me from a potential PC rupture where the capsule has jumped up and it actually touches your second instrument instead of your phaco probe. So that's a technique I always use when removing my last segment. Alright, so luckily not too much cortex left, as we often see with these brunescent cataracts, but just going to go and clean up what is there. So I'm going to use a bimanual technique, which is my preferred technique. And we're just going to go looking in the periphery, trying to find any bits of cortex that could be hiding away. Even though it doesn't appear like there's much, there might be some sticky segments hiding away from us. Doesn't seem to be too much here in the superior segment. So now I'm going to go look on the inferior segment, and there we find a little piece of nucleus sneaking away in the nasal corner there. So just going to use some manual force to plunge it into the opening of my aspiration cannula here. You do run the risk of occluding your aspiration cannula, actually blocking it with a small fragment of nucleus. So may have been better to either remove that with my phaco probe or try and bring it out through the main wound, but luckily I managed to get away with it there. Now just filling the bag in preparation for our IOL implantation, and here I'm actually using a toric IOL for this patient, which had I think 6 diopters of astigmatism and a cornea that wouldn't be a good candidate for laser refractive surgery post-operatively. We did explain to him that there was a risk that we might not get the axis 100% right due to the thick brunescent cataract, but he did understand that we may need to take him back and rotate the IOL, but fortunately he actually had a very good outcome and was very happy with his vision post-operatively. I think he was 6'9" uncorrected. Here the anterior chamber, though, we can see wants to shallow, so in this case it would have been a good idea just to keep a second hand infusing VSS into the anterior chamber while removing our infusion cannulas. So didn't do that in this case and managed to get away with it, but that's something I would like to have done. Now we're just going to assess the axis of our IOL, and fortunately this IOL was very close to the target axis already following implantation. I really like to take the time and get a really good view of the axis of the IOL. The area of parallax, you can often think that it's in the right orientation, then it actually isn't, so really good just to take some time and have a good look. In this case I think just the superior haptic was a little bit off axis, so just nudge that into a better position. Now the orientation seems to be looking a lot better, and so we can just make 100% sure and then give our patient his intracameral antibiotic and then send him on his way.